Hello, everyone. I'm Dr. Marty Ross, and this is another conversation with Marty Ross MD tonight. We're going to talk about Lyme disease in this webinar as we usually do. I look forward, as usual, to seeing what you have in store for me. None of these webinars are ever the same because you create them with your questions. Tonight I'm actually visiting with you from a home of a friend where I'm dog sitting and house sitting. So it's a little bit of a different setup. And those are images of fish against the wall back there. And there may even be the option that one of the dogs disturbs us here tonight. So we'll see how that goes. So my plan is to be with you over the next hour and a half. My voice is a little bit better. My bronchitis has resolved for the most part since last week. It's still a little bit more to go, but we're getting there. And so I'm anticipating being able to be with you the whole hour and a half tonight. So the way that you can participate in this webinar, there's actually two ways. Number one, you could see what questions people have and how I respond. There's a lot of learning that can take place from that. The second option is to actually write a question yourself. And the way you do that is there's a chat box on the bottom of the screen. I ask that you send it to everybody, all right, so that all of us can see that question. But I will also post those questions on the screen so that the people that are in the live version can actually see it. Now, those questions do not show up in the recorded version, so I will read them out loud so everyone can hear it as well, too. Okay, all right. And so I think that's it. Oh, one last thing. I am doing a recording of tonight's webinar as usual. And my anticipation is that I will get that out to you probably somewhere between 9 and 10 a.m. Pacific Standard Time tomorrow. That's what my plan is. We'll see how that goes. Yeah, so why don't we go ahead and get started here. So this first question is from Jim. Now, hold on here. I just want to make sure I'm not getting any messages. Okay, got it. So this one is from Jim. Jim says, hello, Dr. Ross. My wife has a complex case, ALS, Borrelia, Bartonella, Babesia, and mold. We are operating with hope that treating mold and Lyme will halt neurodegenerative process. Her mycotoxin numbers are very high, and we have been focused on that over the past few months. At this time, she does not seem to be responding to treatment. Current meds are azithromycin, malarone, methylene blue, itraconazole, nystatin, Japanese knotweed, resveratrol, and cryptolepis. Do you have any thoughts on sodium phenylbutyrate as a treatment for Lyme? She has been taking phosphatidylcholine and glutathione via IV plus a lot of oral supplementation. Also, her homocysteine numbers have dropped dramatically from over 9 to 4.6. She has been taking methylfolate and recently started leucovorin. Thank you. All right, so Jim, and I think you've asked about your wife before too. So, but what I'm going to say you're familiar with, but I want to make sure that everyone else is familiar with this too. So, ALS, Lou Gehrig's disease, also known as amyotrophic lateral sclerosis, is a complicated neurologic manifestation that can be due to tick-borne infections. Other illnesses that are complicated neurologic manifestations of tick-borne infections can include MS, can include Parkinson's. And so the one thing I will let you know from working with these complicated neurologic syndromes over years is that even when we have a diagnosis and an idea that these are caused by tick-borne infections, even with treatment, about 25% of people can recover. About 50% of people, we don't see major neurologic improvement, but what we do see is improvement in energy and some of the fibromyalgia, myalgia type symptoms. And about 25% of people just have no improvement at all. And some of that may be just due to injury that can't be reversed, okay? So I don't mean to rain on your parade. I'm just letting everyone know those are the odds here, okay? So, and you are on a very thorough treatment. The only thing you may want to consider with what you're doing here is if you could find a provider, if you're making no headway, even on this oral regimen, is to consider IV antibiotics that might give some more benefit. Doesn't mean it will or not, but sometimes IV may be a little more effective and about 5% more effective, okay? In terms of the phenylbutyrate, No, I have not seen somebody using that for a tick-borne infection. So I can't comment on that. I have to look into it a little bit more. I'm not familiar with that. Okay. All right. Good luck to you, Jim. Hello, Susan. Let's see. Does this combination treat Lyme? Rifampin, cefuroxime, and clarithromycin. In that combination, will clarithromycin work as well as doxycycline would? I saw your website said that clarithromycin and doxycycline treat the same form of Lyme. I have Bartonella also. So to answer your question, so rifampin, in my opinion, is useful against cyst Lyme and may help with intracellular Lyme. So those are the Lyme infection has 3 different forms, 3 ways it presents itself, okay? And that is a spirochete. That's the thing that looks like a corkscrew. There is an intracellular, or we call that L-form Lyme. And then there is a microscopic cyst form of the germ. Rifampin can, in my opinion, picks up the cyst, picks up intracellular. Cefuroxime is useful at punching holes in the covering of the spirochete. And clarithromycin is useful for intracellular and spirochete Lyme as well too. Okay, so I just want you to know that. Generally, I consider clarithromycin and doxycycline substitutable, mainly because they have a similar method of action, and that is that both work in your protein, at the level of your protein production factories in your cells. Those are called ribosomes, and they basically work to block protein production of the Lyme infection at 2 different spots. But effectively, the outcome is the same, okay? And either doxy or clarithromycin could be used in a Bartonella treatment as well, too. In terms of this regimen, the Bartonella part of the regimen would be clarithromycin rifampin or doxycycline rifampin, okay? Now, the only comment I would make on this protocol is that you're missing something for a growth state called the hibernator or persister growth state. So although, as I mentioned, Borrelia has 3 different occurrences, 3 ways it looks: spirochete, corkscrew, intracellular, and cyst form of the germ. The thing is that those forms all can have a growth state or a hibernator state. We call those hibernators persisters, and we now think we need to do something to deal with that, okay? Bartonella also has growing as well as persister states of the germ too. And so one thing you might consider doing to simply add something that will pick up persisters would be to add a product called Liposomal Cinnamon, Clove Oregano Essentials. It's by a company called Dr. Inspired Formulations. You can find that product through my store at treatlyme.com. I'm one of the couple vendors that carry that, so feel free to do that. And the reason I like it is the oils that are in there have been shown to be useful against growing and persister Lyme and Bartonella. In addition, experiments from Johns Hopkins University a number of years ago would suggest that it's also breaking apart biofilm. And biofilm, as you know, is a slime layer that covers germs that can block out the immune system and also block out the antibiotics. So it's a way of dealing with that biofilm layer as well too, okay? And you could easily add that to this triple antibiotic regimen that you're on as well too, okay? All right. Good luck, Susan. I hope that gives you some useful information there. So I'm going to just do a quick screen share here. Interesting. Okay. The webinar jam keeps changing how I can show things to you. So Webinar Jam is my platform here, everyone. All right, so this is my website, Treat Lyme by Marty Ross MD, and through here you can find my supplements or the Marty Ross MD supplements as part of the site. Okay, all right. So in terms of this product I was just telling you about, is by Dr. Inspired Formulations, and it is this one called Liposomal Cinnamon, Clove, Oregano Essentials. Okay, that's the product you want. All right. All right, let's go over here. All right, there we go. Okay. All right, Eric, let's see what we got here. Hello, Eric. Let's see. Hi, Marty. I hope you are well. I am. Thank you. Is there any effort on the part of ILADS to establish somewhat of a standard of care for tick-borne infections rather than different practitioners doing different treatments? Also, has there been any effort or discussion of making ILADS conferences available to the public online so patients in rural areas and those with financial constraints can learn from the top LLMDs? Thanks, and sorry about the Mariners. Oh, that was a sad last game, Eric. I got to tell you, you hit the core there. Everyone, as you know, I'm back in Seattle, and one of the baseball teams I follow is the Mariners, and what a shocking loss they had in Toronto the other night. So ILADS is a professional organization, and those meetings are designed to train physicians, and so. Although there are maybe some things that could be learned by the public, or there'd be a lot of things that can be learned by the public, the focus has always been more on training of physicians. So my understanding, I haven't heard of any discussions within ILADS at the board level to try to broadcast these outside of physician to physicians. Okay, so I just want you to know that. And then this question of standard of care, the problem that we run into with it is that, and mostly, how can I say this? When you look at groups like the Infectious Disease Society of America or the American Heart Association that develop guidelines, a lot of their guidelines are developed with great science behind them. There's a base of science that has been done researching different options of addressing problems in people, and they have that data to stand on, okay? The problem in the world of tick-borne infections is we do not have adequate human studies about what works. And so therefore, trying to come up with a standard protocol is just too complicated. You would have tons of objections because some people would say, well, that's not the way I do it. And then they would say, show me the science that works. And the trouble is, I will tell you honestly, that science is limited. Okay. So there is not an effort underway to standardize care. On the other hand, ILADS has come up with a fellowship program where I could pay ILADS money and I could sit and take an exam to show that I have adequate knowledge to treat tick-borne infections. But even within that, there's not a standardization, if you will, of the way to handle the illness. Okay. All right. All right, Eric. Thank you. Hello, Kelly. Let's see. What do you know about the Oshtorin syndrome, PANS, H363D, inability syndrome, or anyone who treats homozygous HFE, H360 gene mutation leading to toxic, non-transferrin bound iron deficit in brain, liver, etc., linked to six-pig study? I do not know anything about it, and nor do I know of who would. So I apologize for that. Okay. All right. Good luck to you, Kelly. Hello, Travis. Let's see. I've been treating for the 3Bs for several years. Hold on, everyone. I've been treating 3Bs for several years. I've already done antibiotics and SOT, unsuccessful. And now I'm about 2 months into a Buhner-style herbal protocol, still working my way up on doses. My LMD wants me to retest with IGeneX and TLab, but I don't see the point. Is testing reliable enough? Should treatment be based on only symptoms? I've already tested multiple times through Vibrant, IGeneX, TLab, etc. over the past 2 years For reference, I just tested 6 months ago, stopping treatment for 2 weeks just to test feels like it could set me back. I want to avoid anything that could derail any progress. Also, have you found hydroxychloroquine useful for reducing symptoms and toning down herxing, or more likely to cause herxing? Have you seen solely herbals work for treating odecoilei? Lastly, do you find that ANA often comes back positive with tick-borne infections? If so, what? All right. You slid a lot of questions in there. I'll be glad to address those. All right. So a lot of my colleagues, physicians, do multiple testing and retesting, and I totally disagree with that approach. Part of the problem in medicine is we're taught to test, and if we have lab evidence of something, then that's what we must use. And doctors are designed to test. That's what we're just designed to do. Now, that would be great if we truly had a test that proved whether an infection is absolutely present or gone. All right. So a lot of these providers are retesting you to see, is there any evidence that the treatment is working? The sad point is that we do not have validated ways of seeing if a treatment is working. Okay. So let's look at a couple of those. So the T-Lab test. T-Lab is a microscope exam that takes a genetic marker and applies it to the germ so that it lights up under the microscope. So when you do a T-Lab, if there is if the germs light up, it is proof that the infection is there. Okay, all right. The problem is if the germs don't light up and they're not there, that doesn't prove the infections aren't in you. It could just be a sampling error where when you drew the blood, the germs were not in that sample of blood that were drawn. All right. And especially with Borrelia and Bartonella, these germs do not readily live in the blood. So the problem with direct testing, where you try to see if a germ is there, is that there's been no studies done looking at what we call the sensitivity, the ability of the test to see a germ when it's there. Many of us believe that the sensitivity of these direct tests to measure if a germ is in you is low. Probably 60% of the time it'll show up if it's there, maybe 40% of the time not. But even T-Lab, IGeneX and its fish test, which is a direct test, IGeneX and its culture, none of these labs can tell us how sensitive their tests are at finding a germ if it's there. So the thing about T-Lab is if you get it done and the germ shows up, yeah, you got proof it's still there. But if a test comes back negative, it doesn't exclude having the infection, okay? If you look at the other thing, that there's another way that people will do, they may redo IGeneX. IGeneX immunoblots are antibody testing, and they may say that if there's less antibodies showing up, that means the treatment must be working. Well, it could also mean that if there's less antibodies or no antibodies showing up, that the immune system is losing the battle and is getting suppressed in a way that it can't make enough antibodies. So less antibodies does not prove the infection is getting better. No antibodies does not prove the germ is gone, because the germ could still be there partying on, suppressing the immune system. So doing IGeneX immunoblot repeat testing is worthless too. And then finally, some of my colleagues like to do the InfectoLab and Armin Lab ELISpot. And ELISpot is a way to see if your T white blood cells have recently seen one of these infections, all right? And the way that the test is done is you draw a person's blood, you take out their T white blood cells, you put them in a test tube, and then you take proteins from the germ you're testing for, like Bartonella proteins, for instance. You put it in the test tube, and then you see, do these T white blood cells release cytokines? If they do, it means they've seen the infection. And the thing about the majority of your T white blood cells, they're circulating T white blood cells, they only live for 2 months. So the people that advocate retesting for the ELISpot test and the InfectoLab and Armin ELISpot test, what their idea is since T cells only live for 2 months, if you or circulating T white blood cells only lasts for 2 months. If you test and the ELISpot is negative, they would say that means the germ is gone. What I would say is wrong. It may mean that the germ is hiding away or sending out chemicals to suppress the T cells. And so it's just not being seen or detected, okay? So on all fronts, there is no testing that we can do that says reliably that tick-borne infections are gone. And I just, my colleagues are stuck in the physician training that we test for everything instead of putting their clinical brains on to say, does it look like it's still there or not? All right. So what I like to do is go by symptoms because we do not have reliable testing that proves that we're done. Okay. All right. Then let's see. So I agree with you. Okay. So then let's see here. Okay. Regarding hydroxychloroquine, hydroxychloroquine, everyone, is a quinine type medicine that was originally designed to treat malaria. But it's horrible. It doesn't work on malaria and probably doesn't do anything for Babesia either. Okay. Although that's not a fair thing to say. We can use it in combination with other antimalarials, the quinolines, which would be tafenoquine or primaquine. Sometimes coupling hydroxychloroquine with those can be effective. Okay. All right. But in general, most of us are not using it as an anti-infective. There are some people that I think falsely believe that it's a good anti-cyst agent, but there has been alternative studies that would suggest maybe it triggers more Lyme cysts to be made. So I don't use it as an anti-infective either. So the role that it can be used for, there's two things that I think it can be useful for in tick-borne infections. So number one, when Borrelia is living inside of a person's cells, so the intracellular form, it goes into what are called vacuoles, little spaces within the cells. And in there, it creates an acidic environment. And that acidic environment can derail the effectiveness of your macrolides, which would be biaxin, azithromycin, or your tetracyclines, minocycline, doxycycline. So what hydroxychloroquine can do is it can change the acid environment in those vacuoles to make them more basic so that you have better chance of your macrolides or your tetracyclines working. Okay, so that's one reason to use it. Second reason to use it is it's a pretty good anti-inflammatory. And in fact, the number one prescribers probably of hydroxychloroquine in the country would be rheumatologists because they use it for the kind of inflammation we see in arthritis, which would usually be due more to what are called prostaglandin type inflammatory chemicals. In addition, though, it does have some ability to limit cytokine inflammation chemicals that we see within tick-borne infections. So yeah, it could help tone down herxing. In my feeling, though, I think it's better to go with the herbs. I find them like curcumin, like cytoquel, those herbal compounds, quercetin, I think are more effective at interrupting a Herx reaction. Okay, all right. And then let's see. So you asked, have I seen solely herbals work for odecoilei? So everyone, odecoilei is Babesia odecoilei, which has gained a lot of attention here as of late. It's a newer idea on Babesia. It's a type of Babesia that's that we did not recognize for a long time. We still do not have the greatest way of testing for it, although T-Labs has a microscope exam for it now. But in IGeneX, if you do the IGeneX immunoblot and you have a positive species Babesia test and don't get a positive microti or Decani test, then that species being positive we think is probably due to Babesia odecoilei. Okay, so odecoilei is a harder to treat form of Babesia, and one of the reasons it's harder to treat is it has the ability to wrap itself up in your blood clotting protein called fibrin, and odecoilei along with fibrin sticks itself up against your blood vessel walls and hides itself from the immune system and antimicrobials. All right, so it's harder to treat. Some of us are finding success using tefenaquine coupled with atovaquone, maybe coupled with azithromycin, maybe throw some cryptolepis in as being something that might work. Sometimes, in my experience, the brother-sister of tefenaquine called, don't blank on it. Oh, I'm going to have to look it up. I just blanked. Starts with a P. Primaquine. That's it. Primaquine. Primaquine coupled with atovaquone, maybe coupled with hydroxychloroquine, I have found to be effective too. Herbally, I have seen cryptolepis as a sole agent be effective, but I don't think it's as effective as your tefenaquine-based treatments or your primaquine-based treatments. Okay? All right, that's what I would say to that. All right, and then finally, ANAs, anti-nuclear antibodies, everyone, are a type of reaction. So anti-nuclear antibodies, nuclear means genetic material. And in certain illnesses, we develop antibodies against our own genetic material in our cells, okay? So our immune system starts attacking our own cells, all right? That is seen in a condition called lupus. It can sometimes be seen in rheumatoid arthritis and a number of other arthritises, but it also can be seen in tick-borne infections. So when you get back a positive ANA, it may just be due to your tick-borne infections triggering the body to attack its own genetic material. But often as you get rid of the tick-borne infections, it seems to go away. Okay? All right. Thanks for your questions there, Travis. Hello, Abby. Let's see. Having issues with parasites that I believe were in GI and penetrated the abdominal wall and now are in tissues. Constant movement of several foot-long slinking worms, large gaping wounds breaking open, sharp poking under skin, burns showing up from underskin, feeling of being wrapped round and round. What can I do to kill it? Have tried extended courses of etoxicide, mebendazole, fembendazole, ivermectin, praziquantel, oregano, clove, etc. So, Abby, I'm not sure because I'm not convinced that these are parasites in your abdominal wall. I know you are. I'm not convinced of that. And if so, this armamentarium that you used on it probably should have taken care of it. And I know, so the one thing, and I don't know enough of what this looks like to be fully sure about what I'm ready to say is right, but there is a skin condition that happens in tick-borne infections called morgellons that will often give you feelings of things crawling around under your skin. You will get breaking down, non-healing skin. You can get fibers that come out. These areas itch a lot too. That's something called morgellons. And what we know about morgellons, those wounds and areas have been biopsied before and not found to carry any parasites. What we think happens is that morgellons is probably more of a skin manifestation of the tick-borne infections. And as you get the tick-borne infections under control, often those skin manifestations that some people think are that they have an impression it's parasites in them go away. Okay. So anyhow, those are my thoughts. Okay. Good luck to you, Abby. And actually, I think I have a whole article on morgellons. Let's go ahead and take a look here. Yeah. So this is my article on morgellons. A lot of it's a video article, but take a look at it. That may give you some insights as well, too. All right. Let's see here. Hello, Susan. Let's see. what works best for the cyst form of Lyme? Does rifampin work or is tinidazole better? 2, what treats persister form of Lyme? Do only herbals work? All right. Great question. So in terms of what works on the cyst form of Lyme, so again, earlier tonight I described we have 3 forms. There's the spirochete, there's intracellular Lyme, and that when it moves inside your cells, it actually loses its covering. And then there are what's described as these microscopic cyst forms of the germ. So what we think is that tinidazole and metronidazole are going to be your stronger anti-cyst agents. Now, those are in the same family. In addition, I have used another azole member, which is fluconazole, as my anti-cyst agent and had good benefits as well too, okay? But my impression is that the azoles are going to be your stronger anti-cyst agents. From an herbal standpoint, grapefruit seed extract can be useful, but also any of the herbs that kill Borrelia are going to go after the cyst form too. So that would be like your crypto, Japanese knotweed, cat's claw, otoba, teasel. They're probably all going after the cyst form of the germ, including the oregano, cinnamon, clove oreganos. Okay. All right. Then, in terms of persisters, there's a whole article I've written about what works for persisters or what's been shown. Okay. So from a prescription standpoint, it is possible dapsone, although I'm not the biggest fan of dapsone because the dosing, it has a lot of bad side effects. Okay. Dapsone may go after persisters. Disulfiram may go after persisters, and even that one has fallen out of disfavor because we think it may not really work that well clinically and it can injure you, which then leaves one other major prescription that can go after persisters, and that major prescription is methylene blue. And if I am going to use a prescription to go after persisters these days, I'm pretty much going to grab methylene blue, okay? Alternatives to methylene blue would be your herbal anti-persisters, and I think these work fine too. And that would be, I think that probably one of your stronger ones would be the combination of liposomal cinnamon, clove, oregano. The other option would be to look at cryptolepis. I think from clinical benefit, I've seen it to be quite useful. Japanese knotweed has got some activity that is anti-persister activity as well too. Okay, so those are some ideas for you to look at. Let me show you the article on that one too. All right, so there's an article called Persisters, What Works? I guess I changed the name of it. It's this one. It's called Persister, Lyme, and Bartonella Options. Okay, and in here I talk about disulfiram, methylene blue, cinnamon, clove, oregano, cat's claw, azlocin, which is not available, etc. Take a look here. You'll see all the options that you possibly have. Okay. Let's see here. All right. Good luck to you, Susan. Hello, Mary. Let's see. How do you decide whether to treat yeast versus SIBO? Isn't it just straightforward to get the SIBO test as there is no test for yeast? I'm very symptomatic, getting worse with increasing bouts of nausea that seemed unrelated to anything in particular. A year of gastro problems, now tapering off all meds to see if there's something in particular. GI ordered hospital SIBO. Is it better to go with Genova or a private lab? Suspect I'm a long COVID person. All right. So SIBO, everyone, stands for small intestinal bacteria overgrowth. And both SIBO, so what in SIBO, you get bacteria living in your small intestines that aren't supposed to be there, or amounts of bacteria living in your small intestines that aren't supposed to be there. So your small intestines are supposed to have minimal levels of bacteria compared to your large intestines, all right? And if you get bacteria up into the small intestines, they ferment food that people eat, leading to gassiness. And so usually that leads to gassiness and bloating, all right? Now, by comparison, there's another problem that people can get, which is intestinal yeast overgrowth, which also can lead to gassiness and bloating. There's a variant of small intestinal bacterial overgrowth that we call SIFO, small intestine fungal overgrowth, which means you've got yeast living up in your small intestines too, okay? Now, the testing we have for SIBO, the best test is to have a gastroenterologist, a specialist, snake a tube down your food pipe, down into your stomach and into the small intestines, and pull out, aspirate some of the liquid down there and send it off to the lab and see, do you have too many bacteria? But the gastroenterologists don't do that. What they instead like to do, and another way to test to see if you have SIBO, is to do what's called a breath test. And in a breath test, you drink a sugar called mannose, and then we see, do you ferment it? And if you ferment it, you're going to make higher amounts of two gases, methane and hydrogen, or one of two gases. We find that if you have a hydrogen-producing strain, it tends to be easier to treat than a methane or a methane plus hydrogen-producing strain. So just to let you know that, okay? Now here's the problem. So the gold standard way to see if you have SIBO is that gastroenterologist snaking the tube down, pulling up liquid, all right? But they don't do it. The breath test, regardless of whether that breath test is done by Genova, in a hospital lab as your gastroenterologist wants to do, whoever does it, the testing, the studies tell us these SIBO breath tests will only find SIBO if it's in you 70% of the time. All right. So it's 30% wrong. All right. Additionally, the SIBO breath test does not pick up SIFO, small intestine fungal overgrowth. Okay. So my approach, even though I acknowledge that yeast and SIBO can look a lot alike, and I also recognize that what people call SIBO is actually fungus, okay? What I like to do is to measure do an evaluation based on symptoms to see if they might have enough symptoms that tell me that it's a possibility they have yeast. So I have people fill out my yeast screening questionnaire. And if they score on this yeast screening questionnaire over 140, what I have found is a good chance that treating for yeast will clear up all the gassiness and bloating symptoms. All right. All right. That's what I have found. Now, partly what that treating yeast may be doing is taking care of both the possibility of large intestine yeast overgrowth and SIFO. All right. Then if treating for yeast doesn't take care of a person and make them better, then I want to go over and look at SIBO because I recognize the testing is not the greatest for SIBO, all right? It's only 70% sensitive, all right? So that's what my approach has been in this, okay? All right. Good luck to you, Mary. In fact, I think I have an article on that one too. Let's go look and see what I got. Yeah, there you go. So this is my whole article on SIBO. And what I suggest is make sure it's not yeast. Go after yeast first. All right. Anyhow, take a look at this. I talk about the problems with testing. I talk about a low FODMAP diet as a means of trying to starve out the bacteria that are fermenting all those sugars. And then I talk about the difference between hydrogen-producing SIBO and methane hydrogen-producing SIBO. Okay? There's also information here about how would I treat them. All right. One other thing that I want to just say. So as many of you know, I do not advocate testing your stool for yeast. Okay? And so part of the problem, when you test your stool, what you're measuring is the large intestines. That stool test is not picking up small intestines. And therefore, you could be loaded with yeast in your small intestines, and yet your stool test comes back negative. All right. So a negative test does not mean you don't have yeast within the intestinal tract. In addition, most of us have some degree of candida yeast living in us. And so if you do get a test and you see yeast there, it doesn't prove that it's an amount that would be causing you problems. And what I have come to think in this whole thing about intestinal yeast overgrowth is that it's not an issue of whether you have yeast in your intestines. It's an issue about whether you have too much yeast relative to what your normal is. All right. So you could get a stool test done and the lab would report yeast in normal range, but that doesn't mean it's good for you. It might be high for you. So I find a negative test unreliable at proving you don't have yeast within the small intestines because it doesn't sample that area. And secondly, having a test that says you have yeast in normal range doesn't mean that it's normal for you. Okay. All right. So I tend to use my yeast screening tool and look to see if people score over 140. So for those of you that are not familiar with my yeast screening tool, take a look in my Lymology guides, take a look at my section on yeast right here. And then take a look at this article called A Silent Problem Is It Yeast? And then down here is my yeast screening questionnaire. Click on that. Again, if you score over 140, that's highly suggestive you have intestinal yeast problems, okay? All right. Good luck to you, Mary. Hello, Susan. Let's see, how to treat someone who has Lyme, Bartonella, Babesia ticconi, or odecoilei. So I always, when somebody has the dreaded 3Bs, as I call them, Bartonella, Borrelia, and Babesia, a central thing that I like to do is definitely make sure I'm covering for Lyme, Borrelia, and then decide which of the two co-infections I want to start treatment with first, okay? So as a general rule of thumb, if somebody's Bartonella and Babesia symptoms are equally disabling to them, I'm likely to treat Bartonella before I add in treatment for Babesia. The reason is based on the observations of Dr. Borrelia, who was kind of a pioneer in treating tick-borne infections. And Dr. Borrealia's observation in his practice out in Long Island was that in situations where he treated Babesia before getting Bartonella somewhat under control, that the Bartonella became harder to treat. All right. All right. So all things being equal, if Babesia and Bartonella symptoms are just as impairing, I'm going to go for Bartonella first based on Borrealia's observations. Okay. All right. Now, let's say that you got Bartonella and you got Babesia, but it is Babesia that is just clobbering you and taking you out of life. In those situations, I will override the, I call it the Borrelia consideration. Okay. All right. That's what I do in my practice. And usually what I'll do is I'll go Lyme and Babesia at the same time, or Lyme and Bartonella at the same time. And as soon as I start seeing improvements in either the Bart or the Babesia symptoms, then I'm going to add in whatever I need to pick up the third germ and run a program that treats all three germs at the same time. Okay. So how do you treat all three germs at the same time? Well, you could use a one option. You could do a tetracycline like doxy or minnow, along with, or instead of a tetracycline, you could use a macrolide like azithromycin or Biaxin. Okay, so use either doxy, minnow, azithromycin, or Biaxin. All right, and pair those with atovaquone which is your antimalarial that's very effective against most Babesia, but not Babesia odecoilei. All right. And so that's a good, and then I would also use, probably I would do a tinidazole with that. Gonna have to do 4 things. It gets complicated. You're probably gonna have to run it with 4 things. You could do like there's no one way to skin this cat. Okay. Let's just say you could do an azithromycin along with atovaquone, or if you have odecoilei, you could do tiffenequine. And then you would want to use, to help improve your chances of getting Bartonella out, you might use a rifampin, but realize that rifampin may alter levels of your atovaquone, and you may need to add even higher amounts of atovaquone in, okay? And you make a decision based on how the Babesia is responding, all right? So if you were to do a doxy rifampin or an azithromycin rifampin along with atovaquone, you've got a 3-drug regimen that will pick up Lyme, Bartonella, and Babesia, all right? If it's odecoilei, you would throw tiffenequine in instead of the atovaquone. And then the only thing you're missing in that regimen is what to do about hibernating persister forms of Lyme and Bartonella. And this is a situation where I might add in liposomal cinnamon, clove oregano, 1 capsule twice a day, or I might use cryptolepis, which also gives you, is useful for persister Lyme, Bartonella, and in addition, it helps pick up Babesia even in a stronger way too. Okay, all right. That's a lot of stuff there. Good luck, Susan. Hello, Susan again. Let's see how to separate lumbrokinase from other medications in food. So what I tell people to do with lumbrokinase, so lumbrokinase, everyone, is a group of enzymes that come from the skin of earthworms. You all have heard me say many times, I find this illness to be so interesting. We have to resort to earthworms to help get rid of it. But lumbrokinase is a strong fibrinolytic, fibrin-busting group of enzymes, okay? The problem is if you have it with other food, supplements, or prescriptions at the same time, it's going to try to digest them and not be left available to digest your fibrin or in the fibrin nest or fibrin that are part of biofilms, okay? So what I suggest people to do, they can have it with water, but you want to stop all medicine, supplements, and food beginning 1 hour before you take it, lasting up to an hour after you take it. So I have people have a 1 hour window on each side of taking it where the stomach has to be empty except water is okay. All right. Oops. Excuse me there. Hello, Jason. Let's see. What would be the best way to find out if anaplasmosis lurks within the other co-infections? I know I have from symptoms. Thank you for everything you do. I'm not sure if I understand your questions. Do you mean it actually lives inside of the other infections? I don't think it lives inside the other infection. Or do you mean if it's there along with the other co-infections? So for anaplasma, I'd like doing antibody testing for it. And that's a method, an IFA method that is done by IGeneX. Even regular PAC Lab, LabCorp, Quest labs can do an IFA antibody test for anaplasma. And I think it's fairly accurate. Okay. All right. Thanks, Jason. Good luck. Hello, Stephanie. Hold on here a minute. If seizures are a symptom of an infection of some sort, does focusing on gut health help, or should the infection be addressed head on? I am interested to know about any herbal antibiotics that would be as effective as regular antibiotics. I am worried about throwing this entire microbiome out of whack, as serious as the seizures are. But if that's what it would take, then so be it. I asked because my son had been given antibiotics for 10 days for positive strep culture, no symptoms. And that was the quietest 7 weeks we had with no seizures. The seizures came back with a vengeance. I don't think he's ever had antibiotics in his life, and I can't recall, so wasn't totally opposed. No other changes at the time in routine. He is mold toxicity, extremely elevated ochratoxin A, and Lyme and co-infection titers and high strep A titers, along with West Nile titer. Currently on well-called GI detox, garlic thyme, LDN, trifortify, CBD, Beyond Balance, and recently probiotics began. And then you have a second part that says, I can't help but think the antibiotics knocked down this bacterial load and gave a small window reprieve for that 7 weeks. Okay. So bear with me. I just want to go back and look at the top here again. If seizures are a symptom of an infection of some sort, does focusing on gut health, or should the infection be addressed head on? All right. So let me just say something. So antibiotics, whether we're using, and by that I mean pharmaceutical antibiotics, not herbal antibiotics, but actually my comment will hold for herbal antibiotics probably too. Antibiotics are anti-inflammatory. They have a killing effect and they have an anti-inflammation effect. All right. So keep in mind, one of the reasons the seizures may have gone away may have had nothing to do with killing any infections. Regarding the seizures, it just may have helped because it's a good anti-inflammatory and led to less inflammation within the brain and therefore less seizures. Okay. So I just need to throw that idea out at you. Okay. So in terms of tick-borne infections, when somebody, if somebody has a tick-borne infection, the infections that I find can be related to seizures or seizure-like disorders are going to be Bartonella, or it's going to be Borrelia. All right. And often as you treat those with either oral antibiotics, I rarely use IV antibiotics, but even oral antibiotics, you can clear it up. Or I found good benefit using herbal antibiotics as well too. And in general, my starting point for herbal antibiotic regimen that's going to cover the 3 Bs would be to use a combination of Liposomal Cinnamon, Clove Oregano Essentials by doctor-inspired formulations. I would couple that with cryptolepis, and if the adult dosing, but you would have to adjust it based upon your child's weight. And so the way you adjust it is the average adult dosing would be for like 150 to 175 pound person. And if your son is half that weight, then you would give half the dose that I'm about ready to say. Okay. All right. So the crypto dosing I like to use for an adult is really pretty hefty if Babesia is on board. And that is to do a teaspoonful 3 times a day. But if there's not Babesia, and I'm mainly using it for Bartonella and Borrelia, I'm going to wind up dosing it in an adult at 1/2 teaspoon twice a day. And then I would combine that with a Japanese knotweed at 30 drops twice a day in an adult. Okay. So the triple combination herbal antibiotic regimen of crypto, cinnamon, clove, oregano, and Japanese knotweed is effective against all 3 of the Bs, and it is designed to deal with the persister forms of those germs as well too, and maybe anti-inflammatory as well. All right. I don't know if that answers your question, but those are the comments I have there. All right. Good luck to your son. All right, let's see here. Hello, Julie. Let's see. Hi, Dr. Marty. I just got results back from several co-infections, uh, uh, B. burgdorferi ospe indeterminate, Babesia microcoti indeterminate, Borrelia recurrentis, Ehrlichia chefens indeterminate. I have CNS Lyme, rheumatoid arthritis, fibromyalgia, CFS diagnosis. I've just started with a new Lyme practitioner. Do you have any suggestions on what questions I should ask her? No, I don't, because I to be able to figure out what you would need to ask her, I need to know more about what your symptoms are. So diagnosing tick-borne infections is not just about the test. And in fact, if you can have raging tick-borne infections and still have negative or indeterminate testing, all right? And so part of the problem and that kind of testing you had done is antibody testing, which I think can be good. But if you've got a lot of immune suppression going on because the germ is so active, you're going to get negative or indeterminate testing from that, all right? So we consider, when making a diagnosis, we consider what do the tests tell us? We consider, is there a risk you could have gotten tick-borne infections, which is particularly high if you've had a tick bite. And it's even more high if you got a tick bite in certain regions of the world, including the Northeast here in the States, where in New Jersey, I think it's like 95% of ticks are now shown to carry Lyme. And so you got to, or if you've got somebody that's doing like major activities that would run them into ticks, like being a hunter, deer hunter especially, or fishermen out there in the wilderness areas. Okay, and then we look at, do you have enough symptoms to suggest that you have tick-borne infections too? All right. So without knowing your symptoms, I can't say what to tell your practitioner. All right. I can say this to you though. Good luck. And I hope this is a person that will help serve you well. Okay. Hello, Robin. Let's see. Is amaurosis fugax a possible complication of Lyme? Babesia, Epstein-Barr, chronic infections, transient loss of vision twice, separated by a week or so in between, associated with change in position. What I can tell you is I haven't seen it occur. I don't know of anyone that's done studies on this one, so I can't tell you for sure or not. Okay. All right. It's possible, though. Hello, Shauna. Let's see. Which of the following products should or shouldn't be taken together, and are there optimal times of day that are better to take each, and why? I'm treating chronic Bartonella, probably got at age 6, and I'm 73. Crypto, Japanese knotweed, cinnamon, clove oregano, black seed oil, Berber panella, curcumin, magnesium, citrate and glycinate, B vitamins, LDN, vitamin D, vitamin C, lithium, thyroid. Okay, so from a timing standpoint, you want to take your thyroid on an empty stomach, and usually that means first thing in the morning, just as you're getting going. The reason you want to take your NP thyroid on an empty stomach is when you take it with other items, it changes its absorption and can lead to some erratic levels of thyroid. So, anyhow, we take it on an empty stomach for that reason. Okay. And then the other couple other things I would consider timing, the low dose naltrexone, LDN, can lead to insomnia. And for that reason, I suggest people take it as part of their morning group of meds. They can take it with other things, but I suggest they take it in the morning. Okay. All right. And then magnesium citrate and glycinate, I usually prefer that people take those at nighttime before bed. And the main reason is they both can make you sleepy. So you can use it and get benefit out of that way. Okay. Regarding the timing of everything else, all your other substances here can be taken together at the same time with or without food, although your herbal antibiotics are going to be better taken without food, but they're still going to probably work even if you do take them with food. Okay. All right. So that means you can take cryptolepis, Japanese knotweed, cinnamon, clove, oregano, black seed oil. Those are your herbal antibiotics all at the same time. You can take them together. Okay. Your Borrelia is supposedly is detox for the brain. I don't buy it. I think there's better things to do, including using liposomal cinnamon, clove, oregano. But I know that's what people use it for. And that I think you can take anytime. Curcumin, you can take with your herbal antibiotics. And I like having people take it up to 3 times a day. Okay. Anyhow, those are my thoughts. Good luck to you, Shanna. Hello, John. I say, hey, Dr. Ross. I'm up to 15 drops of Chinese skullcap and introduced Japanese knotweed. I've been titrating up 1 drop a day and reached 7, but started experiencing increased anxiety, so I dropped it back down. I'm very regimented, and this is the only thing that was changing. Can 1 or 2 drops really cause a herx? It seems like such a small increase to do that. I dropped back down to 5 drops and feel a little better, and we'll stay here for 3 days until better. So the answer is yeah. There is a threshold dose, that a threshold amount at which some people will start to experiencing herxing. And so, yeah, I have seen 1 drop make that difference for a person. Okay. All right. Good luck to you, John. Hello, Catherine. Last week, someone asked about SPM, but we didn't get there. Can you cover this? Also, if you've seen the documentary Under Our Skin about Lyme infection, what is your opinion? So SPM is also known as SPM active. And I actually did say a number of things about last week, but I'll say them again. So SPM active is a product made by Metagenics. And it is basically a fish oil extract where certain fractions of oil are removed from fish oil. And these fractions are found to help resolve ongoing inflammation. So it's known as a resolvin, okay? It's known to complete the inflammatory process. So in long COVID, for instance, this is where we started looking at using this quite a bit. In long COVID, the thought for some people with long COVID, it's that their inflammation process, their white blood cells making cytokines, gets stuck in an on position, even if the germ is gone, and it won't resolve itself. It won't turn off. The SPM active, these fractions of fish oil, are known to turn off ongoing inflammation that is just doing it even though the cause of that inflammation has been resolved, okay? Now, it is possible for some people living with chronic tick-borne infections that at a point, maybe all the antibiotics have completely eradicated the germs, and what they really continue to still experience is unresolved inflammation. But I would consider using an SPM active by Metagenics. Let's say if we're like months down, or I'm sorry, we've treated for a few years, 2 years, and somebody is just stuck and not getting better, I might consider doing a trial of SPF active in that kind of situation. Okay, all right. I'll show you that product here in a minute, everyone, and I'll show you how I build it into a protocol for long COVID as well, too. Okay. And then, so I have seen Under Our Skin. It's scary, but I think that the stories are true. And it speaks of resilience, and it also speaks of the difficulty. The problem is they pick some of the sickest of the sick. And so it really focuses on the fear and the scare part of it. Okay. But I think when it came out years ago, it was a very, very good. So the first version, I think, was very good. I actually have not seen the part two, the redo of that. But yeah, those are my thoughts. Okay. All right. All right. So let me just do a quick screen share here. All right. So if you were to look under in my store and you were to look under metagenics, oh, I guess I'm not carrying it here anymore. That's right. I stopped carrying it. I didn't have enough long COVID people. But anyhow, let me, I'll show you what the product is. Let's see here. Oh, where is it here? All right. So this is what it looks like. Okay. All right. And then in terms of how I would build it into a long COVID protocol, take a look in my Lymology guides, look in my infection plans, and then let's see here. This article here called Solving the Puzzle, the Ross Long COVID Support Protocol. Take a look at this. And in here, I talk about using the resolvins and the SPM active. Okay. All right. Let's see. Hello, Kara. Let's see. What are your thoughts on lymph massage or another modality like a vibration plate for Lyme? So I know there are some of my colleagues that advocate lymph massage or vibration plates as a means of trying to get the germs to kick out of the tissues so that when you're doing testing for them, you have a better chance of getting a positive test. I know they do that. I'm not sure that there's any science that says it really does work. I know that people do that though. I'm not clear beyond. So lymph massage, I think, could be useful as a means of detox. But I also find problems with lymph massage of triggering people to feel worse, probably caused by movement of the germs. Okay. I don't have a strong feeling about vibration plates to help with Lyme or not help with Lyme. All right. So, Kara, see, in your opinion, is red light therapy helpful for Lyme and will toxicity? If so, why? All right. So, red light therapy is something I guess that's getting more popularized by anti-longevity and anti-aging medicine, but it has the ability to be anti-inflammatory, and it seems to promote mitochondrial health as well too. I have had people in my practice and over the and also in my Lyme disease support group that I was running about 2 years ago called Lyme United that reported really good improvements by doing red light therapy. So I think that for some people it can make a difference. I don't know that it's across the board, but again, the way it would be working is it's going to be helping as an anti-inflammatory, and it's also going to be helping by promoting mitochondrial health. Okay. All right. Good luck, Kara. Oh, looks like we already answered that one or didn't answer it. I just don't have an answer for you on that one. Let's go back here. Hello, Josh. Let's see. I've had I have had all the symptoms of Lyme, but tested negative twice. What test do you recommend that Medicare, Medigap might cover? And how long does one generally need to be on antibiotics? Currently on third round of doxy and second round tinidazole. Separate question, does Lyme get confused with fibromyalgia? Yes. All right, so about your last question. So yes, it does. So Lyme and fibromyalgia and Lyme and chronic fatigue syndrome can often look very much alike. In fact, in 2000, when I first opened my first private practice, I opened it so that I could start practicing integrative and functional medicine. One of the first skills that I added to my clinic was doing acupuncture. And as I was introducing acupuncture, my waiting room started filling up full of people with fibromyalgia. And that brought people with chronic fatigue syndrome. And quickly, my family practice, primary care, integrative medicine clinic became a fibromyalgia chronic fatigue clinic. Okay. In 2004, one of my patients asked if I could test her for Lyme disease. And at the time, I was very naive. And I said, okay. And we did, and I did the worst test you could do as a screening test. I did a DNA PCR test to see if the genetic material was in her. The reason I say that was a bad test is that PCR testing for Lyme, Borrelia, will only find it if it's in you 30% of the time, which makes you wonder, as a side here, I know that many of you are looking at the idea of doing SOT therapy. When they develop the SOT product for you, they're relying on PCR testing to see if you have the germ in you. Well, they're relying on a test that can only find it 30% of the time. So it's confusing. And so when they say, well, and if they treat you and they go back and retest again and they have a negative PCR test, what I would tell you is, so it's negative when you have Lyme. It only finds it when you have Lyme 30% of the time. Okay, that's an aside. All right, separate issue. All right. But anyhow, so she came back positive. So her 30% of the time positive test came back positive. Okay. And so it was an eye-opening experience for me. So what I did based on that is I thought, I wonder if a lot of my fibromyalgia and chronic fatigue patients in my Seattle practice have Lyme. So I went and tested all of them. And I found about 35% tested positive for Borrelia, okay? And at that time, I wasn't testing for the Babesia and Bartonella, but 30%, right? So yes, it can be confused. And people miss the fact that really the condition that's causing the myalgia muscle symptoms is a tick-borne infection, okay? And then the test you might want to look at, so the best testing method to see if you have infection, in my opinion, is the immunoblot methodology that is used by IGeneX. And essentially what we're doing, the IGeneX immunoblot is a test method to see if you're making antibodies against the infection you're testing for. Why it's a better test is for Borrelia, they're looking to see if you have antibodies against 8 strains versus your standard lab, like a LabCorp, PacLab, et cetera, is only looking to see if you have antibodies against the original East Coast strain discovered first in the 70s, okay? So it gives a bigger fingerprint, all right? Secondly, what IGeneX does is to make sure that you're not going to get a false positive test, is they grow clean versions of these Lyme proteins in bacteria in their lab. And when I say clean, they basically remove any parts of the proteins that might attract an antibody that was made against a virus infection, all right? So they're decreasing your chances of getting false positive tests, all right? So the IGeneX methodology, when they've studied it, has the ability to find Lyme, if you have it, 93 to 95% of the time. And when it comes back positive, it is correct 100% of the time. That's a good test, okay? Now, to get your Borrelia Lyme test done, you want to do an immunoblot, IgM and IgG antibodies. That's a $450 test. My understanding is that Medicare is paying for that now. But what I would urge you to do is to give a call to IGeneX and ask them, is Medicare paying for this? They'll be able to tell you whether it is or not. Okay. All right. So it's the immunoblot for IgM and for IgG antibodies against Borrelia. And if you want to be really specific, you want to tell them the test numbers that you want. And let me show you where you find that information. So look under my article. It's called The Best Test. All right, this is the article. And I describe why I think the immunoblots are the best way to do this. And the Borrelia test numbers are 325 and 335. 325 is for IgM antibodies. 335 is for the IgG antibodies. And you actually need both, okay? All right. All right. Hello, Joyce. Says, hi, Dr. Marty. In a person with late-stage Lyme disease, Bartonella and Babesia, all diagnosed in 2016, what is driving the muscular pain, especially upper body, primarily arms, currently taking Japanese knotweed and crypto? Any thoughts and or suggestions about herbals? Otherwise, very healthy and led a very holistic lifestyle. Thank you, as always. So, Joyce, it's possible this is all inflammation triggered by your infections. But part of my job and part of what I do when I see somebody is to make sure it's not something else. All right. So, for instance, and this is not quite an identical thing, but I had a patient of mine, a client of mine that was visiting with me online yesterday. And one of her concerns is that she was having a lot of bad knee pain, and that it meant that her tick-borne infections were coming out of, or that she was relapsing from tick-borne infections. And her age was, I think, 70-ish, which is an age at which you can develop osteoarthritis or wearing down the cartilage in the knee. And the more I talked with her, I really came to the conclusion it probably was more osteoarthritis. Okay. Now, with your kind of pain, I would need to ask you a lot of questions to see if it's something that is not Lyme related, but I would want to do that by asking you a lot of questions. All right. So in terms of the best herbal approach for a Bartonella, Babesia, and Lyme, again, I would take a look at my favorite, which is the cinnamon, clove, oregano essentials, the Japanese knotweed, and also the cryptolepis. All right. And you can see these options a few places. I'm just going to do a screen share. All right. So take a look in my here it is. Take a look at my Ross protocol, and you'll see down in the Borrelia section, my Lyme infection section here, that I talk about option 3, which is Babesia, Bartonella, and Borrelia treated at the same time with herbal antibiotics only. And I list out crypto, Japanese knotweed, cinnamon, clove, oregano combination. Okay, so that's one place you can find this information. The other place that you can go to find this information is there's another article. It's called The Best Herbal Antibiotics for Lyme, Bartonella, and Babesia. And I walk through a number of options here, but come to the conclusion that really the best option is that crypto, knotweed, cinnamon, clove, oregano. Okay. Good luck, Joyce. Thanks for the question. Hello, Brendan. Let's see. Hi, Dr. Ross. Do you have any advice you could share on considerations for treating suspected mold illness in a toddler? They are seeing a naturopath with experience in mycotoxin illness and getting a real-time mycotoxin test and other tests to ensure there aren't other issues. Are there any specific considerations or risks you would consider for a 20-month-old for taking cholestyramine that are different to adults other than dose adjustments for weight and minerals? Thank you for your advice. No, there actually isn't. I mean, it's the same testing principles. With cholestyramine, you do want to be careful about constipation, but I worry about that in an adult too. So I don't have any different considerations for your 20-month-old. Good luck. Yeah. Hello, Susan. For Lyme and Bartonella, does only oil of oregano work in place of the liposomal cinnamon clove oregano pill? So I think it is the most direct substitute. So for instance, in the liposomal cinnamon clove oregano, the amount of oregano in there is 75 milligrams. In the oregano only pill by Doctor Inspired Formulations, their Oregano Essentials, it is also a 75 milligram pill. The cinnamon clove in the cinnamon clove oregano does give you more added benefit, but in terms of whether the oregano by itself can work well, it can. And so I tend to go with the oregano pill when I've got somebody that cannot tolerate either the cinnamon or the clove components, and I still get good results with that. Okay. All right. Good luck, Susan. Hello, Josh. Let's see. I've had all the symptoms of Lyme, but tested negative twice. Likely tick-borne, contracted in May and June. Original symptoms: extreme fatigue, difficulty standing up at first, long-term muscle aches, swelling, brain fog. What test? Oh, we already talked about that. Although you've written your question a little bit longer. All right. So I'm not going to. So anyway, again, the immunoblot, IgM, IgG for Borrelia. Okay. And how long does one generally need to be on antibiotics? Currently on third round of doxy and second round to nitazole. How much better, stronger, biggest things are some fatigue and brain fog, upset stomach? Does Lyme get confused with? Oh, I think I've answered most of that already. All right, I'm gonna move on, Josh. Hello, Barb. Let's see. I'm positive for the 3Bs through T-Lab. I have a history of SIBO, dysbiosis, candidiasis, long COVID, 5 years, and parabellness. Found some parasite cyst. My doc is considering cell membrane stabilization therapy, IV therapy to strengthen cells. How do you prioritize treating parasites versus 3Bs? And do you monitor microbiome health during treatment? So, Barb, to figure out what to prioritize, I would need to know a lot more about your health and symptomatology first. And so I can't say. I don't have a general rule of thumb on that. Okay. So I don't necessarily monitor microbiome health, but I do want a good job of putting people on probiotics while they're undergoing treatment. Okay. All right. Good luck, Barb. Hello, Mary. Do you treat Ig positive mycoplasma? Generally, I don't, but let me round that out a little bit. So mycoplasma, as in Mycoplasma pneumoniae, I think is what you mean, is a common bacteria that is found in healthy people. And so if we were to pull a lot of healthy people off the street, people without any health problems, and we were to test them, we would find Ig antibodies against mycoplasma. We think that mycoplasma is an intracellular infection that cohabitates with us and that our immune systems can keep it under control. So if you do test and get IG positive, just because they're making IG antibodies does not mean the germ has gotten active. So some of my colleagues make the assumption that if your IgG antibodies are high, that it must mean that the germ has gotten quite active. And I would say there's no science that proves that, okay? Second, so my argument is we really can't tell by looking at antibody levels whether the immune system has lost the battle against this infection or not. If it is losing the battle, it's because you've got tick-borne infections in you that have suppressed the immune system that allow the mycoplasma to grow. And so I also believe that even if the IgGs are real, let's say they actually mean the germ is getting out of control, my approach has always been go after the tick-borne infections, turn the immune system back on, okay? Finally, most of the antibiotics that we're going to use for intracellular Bartonella, and all the antibiotics we use for Bartonella are intracellular, and for intracellular Lyme, all of those antibiotics, whether it's rifampin, doxycycline, azithromycin, minocycline, Viaxin, all of those go after mycoplasma. Hutania goes after mycoplasma. Your Japanese knotweed probably goes against mycoplasma, right? So the things we use to deal with tick-borne infections kill mycoplasma as well too. All right. Hope that answers your question. All right. Good luck to you, Mary. All right, everyone. That's it for tonight. Been good being with you here. And I look forward to being with you again. We have another session scheduled for next week. And then I think I'll take a week off after that. That is a week off from doing these webinars. All right. So all of you, as many of you know, I am offering consult visits where you can get my opinion more directly. And if you are interested in scheduling those, we have room for them. And you would find that information right here. This is at martyrossmd.com. You would go to the appointments page, and on the appointments page, I describe how you can work with me doing my consult service, which is this service right here. Okay, feel free to do that. Probably, I'm on the verge of later next week. I'm going. If everything goes as planned, I'll be signing a lease for my new clinic space here in Seattle, where I can start doing visits with people and telemedicine visits with people that allow me to prescribe. So look for an email coming up shortly on that, but we'll probably be looking at beginning clinical visits in Seattle beginning the Monday before Thanksgiving. Okay. All right. That's if everything goes as planned and we actually get the lease signed in about a week. All right. All right. So good night, everyone. Good being here. Take a look at your email tomorrow morning. We'll get email notification out to you about the video being ready to be seen. Okay. All right. Bye-bye.